To invite my dear friend and a real expert on this subject, Dr. Varshini Shanker from Shaw Eye Center, New Delhi, to talk about what is the new paradigm or the regime that she follows to visually rehabilitate these children.
Thank you so much, Dr. Vaishali. First of all, I'd like to thank Dr. Vaishali for inviting me to be a part of this August group. So I'll be speaking about visual rehabilitation in 2024, what we used to do and what we maybe what are the new directions we are moving towards. So as has been repeated again and again, achieving a good visual outcome requires early surgical removal of the cataract, consistent optical correction of the aphakia, which means that as the residual refractive error changes, we need to be very vigilant about correcting it appropriately, and compliance and occlusion of the other eye, which still remains the gold standard of treatment. So I think this has already been mentioned, but the infant aphakia treatment study basically compared aphakia versus IOL in 114 infants. They found that the final visual acuity which was gained was pretty much equal in both groups, but 50% of the eyes had a poor visual acuity ultimately, with the IOL group requiring a much higher rate of surgeries. So they suggested that leaving the patient aphakic may be safer. But of course, we always need to remember that this was a very controlled study with glasses, lenses, patches, and all being supplied to the patients and them being monitored very closely throughout the study period. So obviously, the compliance tends to be much higher. Dr. Vasavada also had a similar study where they had 60 children with bilateral cataract. They also found that the mean logmar visual acuity at 5 years was comparable between the aphakia and the IOL group. But in our setup, first of all, of the 25 patients whom contact lens was offered, a majority of them declined to use contact lens, and even those who accepted it, ultimately only 2 out of 25 patients ultimately through the study period continued with the contact lenses, which is a very, very important consideration for us in our setup. So refractive correction varies depending on whether we have left the child aphakic or pseudophakic, and whether the child has had unilateral or bilateral cataract surgery. Aphakia, of course, when bilateral, can be well corrected with glasses, contact lenses, and secondary IOL whenever safely and easily possible. And of course, correction of residual refractive error in pseudophakia. Spectacles provide a satisfactory correction for bilateral aphakia. In infants younger than 2 years, we tend to give near dominant glasses. We also need to consider that many of these children have other associated conditions, as can be seen in this child. So they may have hearing aids, they may have a cochlear implant, and their glasses need to be adjusted accordingly. Contact lenses are an excellent optical device, especially for unilateral aphakia. And if we can counsel the parents appropriately, and the parents have some experience with contact lens use, sometimes it is more of a mental block about putting the contact lenses. Once the child gets adjusted, it is the best option. In pseudophakia, now that we are implanting IOLs even the youngest children with a planned undercorrection of 6 to 8 diopters, 6 to 8 diopters is a very high hyperopic refractive error, which is extremely amblyogenic in itself, and essential that should be corrected. So, as has been mentioned, a dilated refraction or an EUA as required. Near dominant glasses in children younger than 2.5 years, shifting to bifocals or progressives once they are of school age, and contact lenses also need to be considered in case of significant anisometropia or IOL surprises. Coming to the amblyopia therapy part of it, what we still follow or patching is still the gold standard of therapy. Stimulus deprivation amblyopia develops due to an obstruction preventing clear formation of an image on the retina. This is less than 3% of all amblyopia, and universally it is acknowledged that this is much more severe and resistant to treatment as compared to strabismic and anisometropic amblyopia, and really cannot be compared with the two, and most RCTs on amblyopia exclude stimulus deprivation amblyopia. Patching as a therapy has been followed for more than 1,000 years, and I would like to go a little bit down memory lane. I found this very interesting article. This was Professor Bahngatter in Germany after the Second World War. He was so passionate about treatment of amblyopia that he set up these amblyopia treatment schools. So this entire building was devoted only for the management of amblyopia. Children were actually admitted there for a period of several weeks. They stayed in the hospital, they received the schooling as well as amblyopia therapy while they were admitted over there. And this is a poster suggesting that amblyopia needs to be screened for in very young children if we are to be successful in treating it. So coming back to our current practice, the gold standard is total occlusion to form in light, which means usually these are occlusive adhesive patches. We don't want to use stick-on patches over the glasses and so on because it's very easy for the child to peek, especially in dense amblyopia. The infant aphakia treatment study suggests 1 hour per day per month of age till 8 months of age, and 50% of the waking hours after that. Moderate amblyopia between 2040 to 2080 can be treated with 2 hours of patching along with 1 hour of near work. Severe amblyopia, more hours of patching works better, so about 6 hours of patching with 1 hour of near work. Atropine penalization is found to be equally effective as patching in mild to moderate amblyopia. It has been suggested that patching, combining patching and atropine may offer some advantage. The major issue with patching, as we all know, is compliance with patching, and we never really know whether what we are advising and what we are getting, whether there is any correlation between the two. The monitored occlusion treatment of amblyopia study has found that patients may be patching less than 50 hours of the 50% of the prescribed hours, and in fact this has been given as a reasoning why the ATS study found that in mild and moderate amblyopia 2 hours may be comparable to 6 hours, because you may be prescribing 6 hours but the patient may actually be doing only 2 to 3 hours. Educational intervention with counseling of the parents, showing them cartoons with popular characters wearing patches and rewards are helpful in ensuring compliance. This photograph shows an occlusion dose monitor to study their thermal sensors embedded on internal and external surface to detect the duration of patch use. These studies have also enabled us to know what is the dose response relationship, and essentially approximately 120 hours of patching for one line of improvement, and this is usually in the early stages. Of course, this goes down as the amblyopia improves. In the early stages, maybe 50 to 60 hours of patching may get you one line of improvement, and once you're on those last 2 lines, child improves to about 612, it becomes very resistant. So these are the demand for new approaches. Why do we need new approaches? We want approaches which will work faster, which will facilitate compliance, which will give us more complete resolution of amblyopia without recurrence, which are effective and practical in older children and adults as well who cannot patch for many hours. So the first of these are liquid crystal glasses, which are basically just a modified way of occlusion therapy. So these are electronic controlled occlusion. There is intermittent flickering of the lens of the better eye, so that it provides patching for maybe 30 seconds at a time. It can be programmed to how much of patching you want. So it may become opaque for 30 seconds out of 1 minute or 15 seconds out of 1 minute. So it has an on and off mode. It's cosmetically acceptable, as well as refractive correction can be given in the same glasses and may be comparable to patching. The newer therapies which we now have are can be divided into 3 categories: perceptual, dichoptic, and virtual reality. Virtual reality is just a platform which can also provide dichoptic therapy. So perceptual learning and revital, I think, is the most common example for this. This is based on the principle that practice makes perfect. So the patient or the amblyopic eye is trained in spatial frequencies in a range that can be improved with repetitive practice of a software-based visual task, improving visual performance by inducing plasticity in the visual system. So the various types of tasks which they perform include gabor detection and letter identification and noise. This is an FDA approved treatment, and it is claimed that it offers up to 2.5 lines of improvement and 100% improvement in contrast. These are the kind of tasks which need to be done. The first one is a darker image task where you may have to identify which is darker, which is lighter. The second one is where the target is present, and the third one which is shifted, which has an offset, and so on. Practically, what we find is that it's quite a tedious therapy, especially for young children, and they tend to get bored and quit quite early because there are no colors. There's nothing very attractive to hold them to it. But older patients who do it definitely report. We've noted about 1 to 2 lines of improvement, but the problem is that does it lead to any improvement in a practical sense for them? So coming to dichoptic therapy now. So the major disadvantage of patching is that patching is only focusing on uniocular vision. It's not focusing on the function of both the eyes together in a binocular setup. So which is the principal underlying dichoptic therapy. And this is unlocking binocular visual function by presenting independent visual stimuli to each eye, requiring the integration of the two images. The image shown to the amblyopic eye is of a higher contrast to compensate for the decreased contrast sensitivity, and the image which is shown to the normal eye is of a lower contrast. These are fun, they are shorter duration, there's no patching involved, and now passive viewing of dichoptic movies as well have come in, which don't require any effort and therefore can be used in much younger children because it doesn't require active participation. So the first one of these, as Dr. Aditya had mentioned, was the Vision Therapy System 4, where you had a TV monitor and you had these liquid crystal shutter goggles in order to facilitate the presentation of the dichoptic targets. And this was an in-office therapy. It cannot be done at home. And it was quite expensive, so I think that is the reason for the low acceptance rate for it. This is just a kind of dichoptic therapy. There are many companies which are currently available, but the principle remains the same. The patient is given red-green glasses or blue-red glasses. The background target is presented to one of the eyes and the moving targets to the other eye, and both have to be integrated and the game has to be played in order to successfully reach the next level. So several companies are available for this at different price ranges. And finally, the virtual reality vision therapy. These are also dichoptic therapies, but which are based on a virtual reality headset instead of using glasses and a monitor. So this video is just demonstrating how this works. So the weak eye, the stronger stimulus is provided to the weak eye, while the contrast sensitivity of the stronger eye is reduced. Ultimately, as the therapy proceeds, the stimulus is equalized between the two. So in the next video, we can see how this exactly works. So the patient or the child will wear the virtual reality headset and basically play a game for about 30 minutes to an hour per day. This is a new concept which has come out. This has also been FDA approved and is available in the US. It's called Luminopia. So instead of playing a game, many of the popular cartoon movies or series which are available for children have been adapted into this. So they claim that they have a very wide range or a wide selection of videos for children to watch. A study has been published which claims that amblyopic eye visual acuity improved by 1.8 lines compared to only 0.8 lines in the comparison group which used only glasses. And I will finally finish by, this is Dr. Santan Gopal's invention, which is the Orthoptec Magnocellular Stimulator. And I think he has a stall over here today as well. So this believes that we have all been working on patching or by stimulating the eye, and instead of this, he believes in the concept of stimulating the central visual cortex. So stimulation of the magnocellular cells by overt and covert attention, which is basically by movement of the eye to fixate on a lighter target or to focus on one particular target while other lights may be glowing in the periphery. Leads to stimulus going to the posterior parietal cortex, increasing the lateral occipital activity. I believe there is a free paper also being presented on this in this AIOS. Our experience, essentially what we find that acceptance rates are low as costs for many of these dichoptic therapies are expensive.
Can we wrap up?
Yes. So overall, the recent plethora of therapies have not constituted the fundamental paradigm shift which we hope for, but they are effective additions to our therapeutic repertoire.
Thank you so much. And as we end the dot on time, well in time, I thank first of all our speakers for being here and sharing all your vast experience and knowledge. And thank you all of you for being here through this course. And I hope it was useful. And see you hopefully next year. Thank you so much. Thank you for being here.